Good afternoon, everyone. Welcome to Facebook Live. I'm Johanna Beliveau, President and CEO with Visiting Nurse and Hospice for Vermont and New Hampshire, and I'm excited to have Dr. Christine Maloney, our Hospice Medical Director, and Dr. Danielle Parati, our Vice President for Patient Care Services, here with us today. We've been doing these Facebook Live sessions to really bring awareness to our community around the services that we provide in home-based care. And today we'll highlight our hospice program. We will have opportunity to answer any questions that you have. If you're live with us on Facebook today, feel free to enter questions into the chat, and we'll make sure we spend a few minutes before we end today answering your questions. So we're just going to go ahead and get started. And my first question will go to Dr. Maloney. If you could tell us a little bit about hospice, the hospice philosophy, and who are the members of the care team working in hospice?
So hospice is designed for folks that have serious illness and a limited life expectancy, thought to be about 6 months or less, although there's some flexibility there, and really focuses on a comfort-oriented approach to care that's based where a patient lives. So that could be the home setting, a nursing home setting, an assisted living facility, anywhere the patient lives is where hospice is going to provide that care. Mm-hmm. The members of the hospice team include nursing, social work, chaplaincy or spiritual care, home health aides, volunteers, although those are somewhat limited during our COVID pandemic right now, a hospice physician, and the patient's attending of record. So sometimes that's a primary care provider who's been following them in the community would be the most common example of that. So that team is really focused with the patient and their family on comfort and what their goals are during this chapter of their lives.
Thank you. I think, as I listen to you, a couple of questions come to mind, and I hear oftentimes from patients and families around the transition to hospice program and the role of their own physician or provider that they've been seeing. So I believe I just heard you say that their current physician or provider, if that's a nurse practitioner or whomever, stays an active role in their care. Can you describe a little bit about how you work with the referring providers to the program?
So the patient, again, gets to pick the person who they want to be their attending of record for hospice. So again, that can be any provider, a nurse practitioner, a PA, a physician. And so my role is more to support both the hospice team and that provider. So there may be some symptom management issues that may be more challenging, and a provider doesn't have as much comfort with some medications that I might, because my practice is focused on hospice care. I'm also available to kind of back that person up if for some reason they're out of the office, they're unavailable, and there's an urgent patient need. And so it really is a team with the patient's attending provider continuing to have a really active role, and me providing a supportive or consulting role to make sure that patients are well taken care of and promptly taken care of during this period of time.
Great. And so if I'm a patient considering a transition onto a hospice program, I don't have to worry about losing my relationship or connection to someone who I might have been seeing for a long time, which is good.
That's correct. We want those folks to be involved. They know these patients really well, and we want to foster that ongoing, provider relationship.
Yeah, great. Thank you. And one last question about the care team. If I'm new to the program, how often might I be seen by a member of the care team? What does that look like?
It really depends on both patient needs and our clinical assessment of what's going on in someone's house. So a nurse might see you as infrequently as every 2 weeks or as often as every day, depending on what's going on. Our spiritual care providers and chaplains usually are seeing patients maybe once a month, maybe every 2 weeks or once a week. Again, it's very flexible depending on patient need and desire and how much and how quickly things are changing in a household. Home health aides, similarly, they might be helping every day with personal care or maybe a few times a week, depending on what's needed for a situation.
Great. Thank you. I'm sure that's helpful to families out there listening today. So Danielle, I'd love to hear a little bit from you. And VNH has been providing care and service in our communities for over 100 years. Can you talk about what that means to you? What does it mean to be a local provider and the role that VNH, in particular, our hospice program, plays in our communities?
One of my favorite questions. The reality is we are our own community. When you choose to live in rural communities of this size, we are members of the community. The people we are taking care of are our neighbors. They might be our children's teachers. Then in some cases, they were the teachers who taught us in school. They're the people we see in the market and the town hall when you can see people in social settings. They're the people we see on the ball fields. We are members of our own community. So when we're taking care of people at the end of their life, it is an incredibly special experience, and it is so unique that we are able to do that and bring truly holistic care into our clients. This is an amazing gift. We get to know not only the individual, but their family and their communities and their neighborhoods. And we're able to really bring out the sense of team and community. For instance, I very vividly remember a case of a woman who really needed to go to the hospital, and a nurse was trying to work with her on her medical conditions, but the woman didn't want to leave her dog. A case manager from another program knows the town, and she knew that the town clerk would take in the dog. And so in a matter of a couple phone calls, this patient's mind was put at ease. The dog was someplace that she knew was going to be safe and cared for. The town had been able to help, and this woman was able to get the care she needed with a relaxed mind about her pet. These are the types of things that VNH, being community members, being in our neighborhoods, being part of what's happening in our communities, that we have the opportunity to do. And it's an incredibly special event. We have relationships with parish nurses who are all volunteers most of the time. We have relationships with EMS. Some of our staff are EMS in their communities. So we know the people who go out on these calls. We know neighbors who are willing to drive or cook meals or snowplow before the physical therapist shows up. And we're able to do this because we are our own community and we are caring for our neighbors.
Yeah, that's great. I love the example about the dog. I hadn't heard that story before, but it makes total sense knowing many of our small villages, right? We do have those relationships. We know our local store owners. We know the people who work at the post office. We know our town clerks. And it really is an advantage for us as we try to find the resources, right, that our patients and families need as they navigate through, in this situation, the end of somebody's life and whatever their care needs might be. So I really love that. That's a great story. I would love to hear you talk a little bit more about, you made a comment just a moment ago about holistic care and holistic care in the community. And I know Dr. Maloney referenced this in terms of the interdisciplinary team. But I'd love to hear from your perspective, Danielle. What does holistic care from the perspective of hospice look like?
I think hospice is the place in the entire United States healthcare system where we truly get to embrace the ideas of holism, where we truly are empowered, not just actually empowered, but required by all of those regulations that people usually bemoan. In hospice, those regulations are the ones that ensure that we not only have the opportunity, but fulfill the opportunity to take care of the whole person. When you look at the interdisciplinary care team in hospice, it is embedded that we have spirituality and we have social services, not just the medical, but the whole person is being thought about in this. Mm-hmm. And when we bring in our volunteers, it adds the whole level of personhood into the conversation. We are able to act every day about what is the person, what are they thinking about, what do they need, as we customize how many visits and who's visiting and what kind of services we bring. This is a very unique opportunity in healthcare. One of the most important things I think people misunderstand about hospice is that it is absolutely about the individual's choice. It is the only place in our healthcare system where the patient chooses and the physicians agree. Everywhere else, the physician says, how about this? And the patient agrees. But it's driven by the physician order and the patient agreement. In hospice, we flip the script. The patient says, I am accepting that this is the end of my life, and I am making choices about where I want to be and who I want to be with. And the physicians are asked to agree with that. And that changes the entire conversation. It means that we really get to ground ourselves in our work in what makes sense for you. It's just a very, very special place in the healthcare system that really takes all of those ideas of holistic care and makes them happen in a person's own home. This is where they want to be. How will we help you stay there?
Yeah, I love that. Thank you so much, and appreciate, for again, those listening today who might watch us later, recognizing that difference between what the patient is choosing in terms of how to spend the rest of their days versus a medical situation where a physician or other provider is directing that care in terms of what they think is the best option or the best intervention for someone given their situation. So that's really unique, and I appreciate you highlighting that. So I think there's actually probably a few things about hospice that people don't understand. And so I'm actually going to ask both of you, and I'll start with Dr. Maloney to chime in on this next question. So hospice is underutilized in many areas of the country and within our own region. And there are some barriers for people choosing hospice. What are some of the myths about care that might be a barrier that you would like to debunk, so to speak?
So I think one of the myths we talked about before was that you lose the relationship that you have with an ongoing primary care provider or other provider that's been involved in your care for a long time. And so we're not making people choose or let go of that person who's been really involved in their care. So that's just something I wanted to emphasize again. Mm-hmm. I think the other piece is that there's a myth, I think, that hospice focuses very much on death. And so I think we actually do quite the opposite most of the time, which is focusing very much on life. How do you want to spend your time? What are the things that are really important to you? What are the things that bring joy and happiness on any given day? And how can we help you make those things happen? And so there's, I think, a myth that hospice is very much about doom and gloom. And I would say that, in fact, it is the opposite a lot of the time. There's a lot of reminiscing. I think there's a lot of life review. There's a lot of discussion about wonderful times and jokes and stories, that hospice becomes an opportunity to do some of that in a very purposeful way that is often very memorable for both the patient and family members or other care providers that might be involved in their care.
I would add on to that time is one of those big myths. I think a lot of people mistakenly think that hospice is only about the last few hours or maybe the last few days, and that it's about this sense of, well, I gave up, so now I'll give in. And it really isn't. It really is about having an acknowledgement of where a person is in their life's trajectory and being able to say, I'm going to live as much as I can for this period of time. So I don't really want to go to the hospital anymore. And there's actually quite a bit of evidence that says that when the hospice team gets involved and really collaborates and coordinates with patients to look at what are the medications and the treatments that are happening, when we can streamline some of those, people actually improve. We have people who feel better and are better able to get out of their bed or get out of their house and engage with their lives and their families for a little bit longer because they have the supportive care that they need to help that situation. And that it's really not about the last few days and hours. We will be there for that. We will be there at those times. We want to be able to support those moments and particularly care for the loved ones after the death. But we are not only about those last few hours. We really are about how do you want to live while you're here? And what do you want to do at this point in your life? It's a very big shift.
Thank you very much. I appreciate that. And having spent some time as a hospice nurse myself, I really appreciate this conversation, and it's bringing me back to why I loved being part of that care team so much, because it really is an incredibly special time in people's lives. And as a care provider, the joy and actually meaning that you get from that experience is often, for me anyways, it was way more than I felt that I was giving. I was always taking away more than patients and families realized. So I appreciate both of your explanations here today. So we have a couple of questions actually from our audience. So I'm going to shift gears a little bit. And of course, COVID-19 is top of mind for everyone. And we've just described sort of what hospice looks like under normal conditions. So we are in the middle of a pandemic, and would love for you to describe, and our audience has asked, how has this pandemic changed the way that we provide services? Is there something that we do differently now than we would have done 6 or 9 months ago? Danielle, do you want to start?
Sure. I can think of 3 things that come to mind. The first is that volunteers. So volunteers are not going into patient homes right now due to COVID risk. We have shifted our volunteers to be more phone-based and communicating with people from a distance. And so that's been really difficult for a lot of folks, particularly the volunteers. To your earlier point, there's such a sense of value when you choose to volunteer for hospice that when you don't get to go in a house and actually visit, it's really disappointing. So yay, let's get COVID over with so we can get volunteers back. The second thing that is really the most visible to patients and families is that our staff is wearing face masks and shields. That in order to do our part to keep the community safe and reduce transmission, since about April, all of our team has been wearing surgical masks and a see-through plastic shield over their face. That ensures that any risk of transmission is stopped because the clinician is neither projecting any droplets nor are they able to receive any from the combination. So it takes a little bit of getting used to see people wearing that equipment, and frankly, a little bit of getting used to wear that equipment. But it is very, very important, and it has been hugely successful. With this equipment, we have had no transmissions across the entire Dartmouth health system, and it's very reliable and important for everyone involved. I think the third thing that comes to mind as we look at what's changed during COVID is that we make a lot more phone calls, and that we are trying to involve video into our phone calls so we can see people and talk with them more regularly, even when we're limited by social distancing. So we're trying to incorporate new ways to connect with people that allow us to keep that communication strong and vibrant, but not always requiring someone physically in the home.
Great. Thank you. 3 very important points. I don't know if you have anything else you'd like to add to that, Dr. Maloney?
Well, this is a slightly a twist on the question of not necessarily how we're providing care, but some other implications of COVID-19 for hospice care right now. And there's 2 that I think of. One is that patients who might in the past have said at the very end of my life, I actually might want to be in a hospital setting. A number of those patients have now changed their mind. And that's usually based on visitation. So because visitors are so limited in the nursing home and hospital setting right now, folks are able to have more people around them at the very end of their life if they stay home. And so we've seen some patients make a different choice because of COVID. The second place where I think I've seen some changes is that there are more and more people, unfortunately, either out of work or working from home, but they then have the opportunity to do more home-based care for their loved one who might be on hospice services. And so they've been using that time to become caregivers, which might not have been a viable option for them before if they were working full-time outside of the home, but now feel like this is something that they can do. And that's made a difference in a number of situations as well, as far as the patient being able to feel comfortable as a hospice patient with a regular caregiver, which would not have been possible in a different circumstance.
Right. Thank you. Well, certainly COVID-19 has changed everything about the way we live and work today. So I know our hospice program is not immune to that. And I also appreciate the work that you are both committed to and that the entire team is committed to around providing as much direct care service as we can in the home, maintaining the same level of quality of service to the community who needs us now as much as they ever have. So thank you both, and I appreciate your sharing that perspective here with our audience today. I have one more question for you, and again, I'm going to shift this to Danielle because it's specific to nursing. So we know that nurses have lots of options, right, in terms of where to work. And so every practice setting, hospitals, clinics, surgical centers, home-based care, we all need nurses, and nurses have lots of choices. So our question is, if I were a nurse working in home-based care, and specifically here in hospice, what would a typical day look like for me?
Well, that's a fabulous question, because I think that so many people really don't have the opportunity to think about what is it like to take care of people in their homes. And it's so different. Care in homes is really an independent place for nurses to practice. It is the place where we actually push the boundaries, push to that top of scope of practice around our autonomy and our independence. On one hand, it's a little bit daunting. I don't know about anybody else, but I still remember the first time I stood at a patient's bedside and thought, I'll go get your nurse. Oh my God, that's me. At that moment of realization, that comes back when you make a transition into the home, because you realize that it's you and you can't poke your head out in the hallway and get a second pair of hands. The benefit of that is the incredible opportunity you have to make a difference, and to make a difference beyond just the immediate, here's a glass of water, but to make a difference in the ability of a person to keep getting their own glass of water, to help them look at how will they be independent when you're not in the house, and to make change and support people for their health and well-being over time. In hospice, that means we get to work with the individual who is at the end of their life, and usually a number of people who care about them. We are able to set our own schedules. We coordinate with patients and families about when we're going to be there. We lead team collaborations to ensure that all of the patient's needs are being met. We're able to utilize our clinical expertise to partner with our providers and talk about the symptoms we're seeing in the home, and really be active partners about what the next step is going to be or how to control the symptoms. We work with both the pharmacological and the non-pharmacological. When you're alone in a home, you can't just call down to the pharmacy. So we really have an opportunity to develop a huge array of skills to think about what are ways that I can help someone feel better when I have limited numbers of medications. That brings us into a whole new space as a registered nurse, and that ability to truly fulfill. I call it the first class of Nursing 101 that we all took, where we talk about holistic patient care and we talk about autonomy in practice. When you are at the bedside in someone's home of a human being who is at the end of their life, there is no place that you are going to practice more independently that is going to rely on your knowledge and your confidence and your skill set anymore than being a nurse in hospice. Mm-hmm. It's all about how you incorporate the challenges and the people in front of you and maximize your team and your resources to meet their needs. It's obviously a place I'm really passionate about.
Yeah. So
I say, Danielle, I can think of a comment that a patient made to me that I had to stop and think about, which echoes some of the things that you said. And he said, in all the time that I was in the hospital, since I've been home, I've seen a nurse way more often than I ever did when I was in the hospital. And I had to stop and think about that for a second. But I thought about how long is a nursing visit in the home, And what is that one-on-one time where someone's not running back and forth trying to get meds or answer another buzzer or something else like that. And he just really felt like he got one-on-one personalized attention from a nurse at home in a way that he didn't feel like he did in a hospital setting.
Yeah. Thank you so much for sharing that. It's such an important point. When you're in a home, you're focused. It's this person. I can think, I can engage, I can actually have a conversation and not be worried about the 3 minutes and the buzzer and everything else that's happening in the hallway because I'm in their home. Thank you. Yes, that's such an important part.
Yeah, I love that too. And actually, I would love to come back around to something else that Danielle described, which was, yes, as nurses in the field in a home-based setting, you are practicing at the top of your license. You have the opportunity to really use your full set of skills and all the knowledge that you've developed throughout your education and your career. But that said, as you've already described, it's a whole team approach, right? And I know specifically you, Christine, talk quite frequently with the hospice nurses in support of what they're working with the patients to accomplish at home. Could you describe a little bit about how you interact with the nursing team to offer them that level of support when they are the only one at the home with the patient?
So I think about our hospice nurses from a provider point of view as being our eyes and ears in a house. And so often this is a quick text or phone call to just say things have changed. And then maybe I have some follow-up questions. Tell me more about what you're seeing. What is your assessment today look like compared to when you were in the house yesterday or 2 days ago? What are some things that you're thinking about for medication changes? What are some things I might be thinking about? And so over the phone, we can come together with a plan. And sometimes that's a 3-way plan on speakerphone to say, what is the family, interested in or worried about? What is the nurse seeing in their assessment in the house? And then what is my kind of take on all of that information to say, okay, this is the plan that we're going to try going forward to see if we can get symptoms into better control. And it's also something that a patient and family feels really comfortable doing at home. And so we might make a change and then the handoff may be back to the nurse to do some education about why those medications are changing or how to administer them if we're using liquid medications and not pills, which might be something that family members are unfamiliar with. And so I think there's a huge role for education as well on the nursing side and this joint, very personalized planning that we do on a regular basis.
Great, thank you. And just appreciating that while a clinician may be the only one in the home at the time with the patient and their family, recognizing that they still have a whole team of people. And so the team is just a phone call away, and that includes our provider staff, our social work team, our chaplaincy team, et cetera. So I do really appreciate the interdisciplinary group that comes together in support of our hospice patients. So we're actually getting really close to the end of our time today. And I would just ask if there's anything that we didn't say today that you would want our community to know about in terms of the hospice program in our last 30 seconds together.
We're here. We are here. We're your neighbors, and we are ready to support you.
If hospice is something you're thinking about, either as a family member, a patient, or a provider, send us a referral. We'd love to look at the information. We have staff that will come out and do a hospice informational. So just to have a discussion about what is hospice to see whether it's something that fits for you right now. And if not now, maybe later, so that you're really informed about the choices that you have about your care going forward as your illness continues to change.
Great. Thank you. Both really important tips at the end of our conversation here today. So thanks again to everyone who is listening in and watching for this Facebook Live edition. And we hope to see you at future events with the VNH. Take care and have a happy Thanksgiving, everyone.
Thank you.
Thank you.